back in the mid 70s and set up and took part in a community health project a week's walk from the road. So think about that, working in a place a week's walk from the road. And it was in a very primitive society where they, oops, what am I doing here? Where they had shamans or spirit mediums. So this is in the valley where I worked, and this is a jonquery or a spirit medium, because people believed that spirits would affect them and they would get sick, and so they needed someone to get into their spirit world and tell them what needed to be done. In the 1980s, I was fortunate to set up a remote district hospital in Nepal and train Nepali doctors. And here's an example of the primitive things I did. I taught open drop ether anesthesia, for example. It's simple technology that has always been my focus in the 11 years I've spent in Nepal trying to do things in a simple manner. I then about got obsessed with what you're going to hear about today, and I would try and speak about these ideas in as many forms as I could. Here I'm on Amy Goodman's Democracy Now! Here's a TEDx talk at UW. You'll see a graph like that soon. And this is my wife and son and daughter a couple of years ago below a mastodon. And now, at age 80, I become a grandpa. So this is my son, Malachi, messenger of God. It's just a delight to now take on becoming a grandfather. So I want to look at, so that's me. I'll ask a little bit about you later. So I want us to look at U.S. health outcomes in comparison to other countries, suggest that the reasons we do so poorly are political, suggest that even though I've worked as a doctor for 40 years, 50 years, healthcare has relatively little to do with that. And then what are you going to do, you residents and doctors you become, to promote health? So I'm going to suggest introductions. Arita, I hopefully well, she sent out a quiz. I'm going to ask you to look at the quiz and then do a breakout group discussion. I then want us to look at vital signs of populations. And so we'll do some Zoom polls there and a breakout group discussion. So, I have all this time, so I'm trying to get you involved in a variety of different manners. And then we'll finally take a break, um, probably at the end of an hour. Then look at what produces health in a society. Look at our healthiest state and what its Department of Health says are root causes. Ask you to do a ranking in the chat. Some of you have done that in the website and talk in a breakout group, and then we'll have another break. And then we're going to switch gears and talk about medical harm. What does medical care do that may not be favorable? And talk about medical reversals, things we didn't used to do that we do now, and things we did then that we no longer do now. So medical harm, after that, I want to look at early life, because the about half of our health as adults has been programmed in the first 1,000 days after conception. And I want to talk about adverse childhood experiences, or ACEs, and their impact. And then have another case and a breakout group discussion on that case. And then you're going to be pretty tired. Have another break. Look at state policies in this country and other political policies, and then consider something that you can call social prescribing, which may be much more effective in producing health than the typical things that we prescribe. So there it is, what I hope to cover in this brief period of time. Arita's going to let me know if something shows up in the chat, and at any time, just shout out and talk about things that are important to you. Because I really hope you get a little bit out of this that's really important. So if you want to zone out now, here's what we're going to talk about. Our health is worse than in many nations. The reasons relate to political context and governance. That economic inequality is bad for our health. It kills us. Medical care is a minor player. Student of mine came up with the phrase early life lasts a lifetime to depict the importance of the first 1,000 days and adverse childhood experiences. And what we can do as doctors in creating awareness of U.S. health status. Okay, so yesterday you should have received an email in what Arita sent out, and there were 8 questions there, and I want you to answer those 8 questions. So if you haven't downloaded it, please do. If you can't find it, then here are the 8 questions. And so please complete these 8 questions. They each have a single answer. If we had Slovenia's child mortality rate, how many more or fewer children would die every day? In which country does a 15-year-old girl have a greater chance of being alive at age 60? Sri Lanka or the United States? Rich white Americans die younger than the richest people in these other countries. Question 3. How many UN countries, question 4, have lower life expectancies? United States in 1953 had the lowest maternal mortality ratio, true, false. Question 6, which of the following countries did not see a rise in maternal mortality over that decade? Question 7, a college graduate Black woman has a lower chance of dying in childhood than a white high school dropout. And finally, question 8, according to a study from Hopkins in the BMJ medical care, was the what number leading cause of death? So please circle your answers or make your answers. And if you're ready, I will present the answer sheet and you can score yourself. How many need more time?
Let's give it like 3 or 4 minutes just to.
Okay, another.
I think, I don't know. Those who are on, can you tell me if you need more time? But I think maybe a couple minutes.
Okay.
3 more minutes.
3 more minutes. Okay.
I have a little stopwatch here. I'll set it for 3 minutes. I think we're coming up to 3 minutes. Do you need more time? Okay. So here's the answer sheet. I want you to score yourself. And I wish these kinds of questions would be on your board exams, but I don't think they will be. So please score yourself. And much of the rest of what we'll talk about today will explore a lot of these ideas here. So Arita, if you can put people into breakout groups and then, say 4 or 5 per group and have them discuss what was surprising or what they didn't believe, and then come back again. So a breakout group for maybe 4 or 5 minutes.
Okay, I'm putting people in groups now.
Good. And I'll start the clock for 5 minutes.
Hey, Rita.
Hi, I'm just gonna hang out with you guys. I don't have to say anything.
Okay. We're just like reviewing the answers and trying to figure out how surprised we are. I'm like very slow this morning, cognitively. That doesn't surprise me. I was just really pessimistic in my answers, I think.
I agree. Every time it was like the US versus something else, it was like the US is going to be worse, whatever the category.
Yeah. It was like, how many UN countries have longer life expectancies than the United States? I put 100, but it was 43.
What surprised me was that the U.S. had the lowest maternal mortality in like 1952 than anyone else, which was, yeah, that was probably the most surprising actually for me.
Yeah. Oh, some of these questions are just read like opposite.
Yeah, some of them were like very double negative. Like number 3, I put true, but I meant to put like I knew what the question was asking, that we have like worse, but I was like, yeah.
I'm also still not quite sure what the last one means. Like medical care is like medical mistakes,
Oh, I think it's errors.
errors. Okay, that makes sense.
I think it was supposed to be errors. I'm not entirely sure.
Wow, the third leading cause of death.
Yeah, that doesn't sound right actually to me. I feel like maybe it is. I don't know.
I heard that statistic before.
Really?
It's like iatrogenic causes of
Oh yeah, I see that. I wonder how that's defined. Feels like that's hard. It's like harder to find medical error. I know I said I wasn't going to talk, but that's impossible for me. Medical error is like a little bit hard to define. Like, you know what I mean? Like when you actually dig down into it, like what is a medical error? It's like someone who is like very ill and at the end of their life anyways, but then their official cause of death is a medical error. Like I don't know, they're like getting some kind of lung procedure because they're like critically ill and then they get like a pneumothorax and they die, is that coded as a medical error? When like technically a medical error was the mechanism of their death, but like they would have died anyway. You know what I mean? Like it's a little
Yeah.
bit difficult for me to parse exactly how to interpret that. Okay, I'm gonna return to the main room because I have no sense of time, but you guys should continue discussing amongst yourselves.
Thanks, Arita.
Uh-huh.
Okay, well, I guess we're coming back now. It's close to 5 minutes.
Are we? Okay, I just wanted to check in and see how they were doing, so I can bring them back. I think it sounds like the discussion was about ending. Close
Yeah,
all
The
rooms.
group in the future for breakout groups, can you let me wander from one to another? Because it seems like I could only get to group 9.
I think, well, let me bring them back. I think if I make you a co-host,
That'll do it.
that should do it.
Yeah.
Then when you click on, now you're a co-host. So if you, now when the breakout rooms are there, I think it should let you just like join, not right
Okay.
now, but it should let you just join wherever you want.
I realize it's going to take, the breakout groups are going to be somewhat inefficient, but okay.
I think we have time.
Yeah. So how many do we have altogether?
45,
Oh, good.
including us, everybody.
So when we're all back, can I ask one group to report on their discussion? What really surprised you? What don't you believe? What do you think's going on? Yeah, I think we're all coming back. So if one group could, there could be a spokesperson from one group report on their discussion, that would be nice and give some closure here. Because we're going to look at most of these ideas in the rest of our session today. Somebody want to volunteer?
I'll volunteer. Our group just generally said that we were surprised about some of the statistics. I mean, some of us kind of knew that maybe the US wasn't the best compared to other developed countries, but we were surprised that our life expectancy might not be as great for someone compared to like question 2. And then number 8 really surprised us. Like how they determine leading cause of death, and like we want to know more.
Okay.
And then we got to like a discussion about lifestyle and how maybe that differs across different countries and what foods we have access to. And we discussed like blue zones and that as a concept. So
Good. Okay. So let me go on. So how do you measure health? Well, as an emergency doctor, the easiest diagnosis I could make in the ER was that somebody was dead. So it's hard to fake. All the rich countries track mortality, and in poor ones, there are good estimates. And so I became fixated on mortality rates. If you're not alive, you really can't talk about being healthy. So what nation should we compare? Well, I started about 25 years ago looking at United Nations Human Development Report, and I coined the term the Health Olympics. You know, we compete in Olympic events. Suppose health were an Olympic event, and the race was how long you live, life expectancy. So if health were an Olympic event, the race was how long you lived, so life expectancy. I want us to do a Zoom poll and see how many would give us the gold medal, put us in the top 5, 6 to 10, and if I'm doing this right, I'm going to be able to do a Zoom poll. Where are they? Polls. Here we go. So, oh dear, these aren't the polls I had before.
Say in the other, maybe in a different, we can make one really quickly.
No, let's stop. Okay. So how many would put us in the left hand, somewhere in the top 15, our life expectancy in the top 15? Can you indicate roughly how many would put us there? Okay, we have one hand. I'm not going to be able to monitor how many do that. How many would put us somewhere 16 to 30? That is, okay, more hands go up. Anybody put us below 30? Anybody put us below 30? Are those hands that weren't lowered from before? Well, okay. So let's move on and look at, so we're not going to do the Zoom poll. This is the top 45 countries ranked by life expectancy from the United Nations Human Development Report with data for 2021, the report published last year. So I don't know if I can, okay. So what do you see here? Well, United States ranks 44th. That is among UN countries, 43 have longer lives than we do. And if you look at the countries across the bottom, they're all the other rich countries, and some like Chile or China, Thailand, not quite so rich, Slovenia. And there's about 7.5 years separating the United States from the longest lived country, Japan. So we don't think of life expectancy differences. We have trouble recognizing what they represent. So you probably all know that our leading disease killer is heart disease. If present trends continue, it'll kill a third to a half of all of us. Cancer's number 2, and in 2021, COVID was number 3. So suppose we eradicated heart disease, cancer, and COVID in 2021 as a cause of death. How many life expectancy years would we gain? The answer is about 7. So if we eradicated our 3 leading causes of death, we'd be close to being the healthiest country in the world, but not there, not there. So you're probably wondering why. And a typical thing, and I used to believe this very strongly, personal behaviors matter. So let's take a personal behavior that you probably agree is not healthy, smoking cigarettes. Which country on this list has the lowest proportion of men smoking cigarettes? Somebody want to voice it? Which country on this list has the lowest proportion of men? I see somebody in the chat. USA, that's correct. United States and Sweden have about 15% of men smoking cigarettes. Which country in this list has the highest proportion of men smoking cigarettes? Anybody been to Japan? Japan, about 45% of, yes, good. Joey Chunyin and Kristen Stevens got the right answer. About 3 times as many men smoke cigarettes in Japan as in the United States. So personal behaviors, although they're important, certainly smokers have worse health than non-smokers, whether they're in Japan or in the United States. But in Japan, the difference in health status between smokers and non-smokers is not so big. So something else is going on. And we can similarly take apart other personal behaviors, diet and exercise. Yes, they're all important. All of us here try to practice good behaviors, but they're not as important as we would like to think. Sorry. Uh, we also spend half of the world's healthcare bill, and we'll talk about that. So healthcare can't be that big a deal in explaining this difference. Now, in the early 1950s, the life expectancy numbers were lower. That is, we've been living longer lives, but the United States was somewhere in the top 5 in the early 1950s. When I went to medical school in 1970, we were 17th. When I went to public health school in 1992, we were 22nd. And so what's been happening is each year we drop further and further behind the other countries, even though, and that is their health improvements are stronger and faster than ours. So this is a graph of life expectancy trends for rich countries in the gray, and their average there, the darker gray, and the United States from 1980 to 2021. And back in the early 1980s, we were sort of in the race. We had life expectancies comparable to other rich countries, but you can see by around 2010, our life expectancy stagnated and then had a big decline even before COVID. So we can blame some of our decline on COVID, but not that much. So all of these, I think we have to believe these data since they represent mortality, and all these countries do a very good job calculating mortality. So 10 years ago, the Institute of Medicine came out with a report, and I want you to read the title, U.S. Health in International Perspective, Shorter Lives, Poorer Health. This was 10 years ago, and explained, it put all the science behind what we knew to be true then, and the call out, we've been dying at younger and younger ages than people in the other high income countries. So I'm always searching around for ways in which we as individuals can try and make sense of this. And so websites allow you to compare your life expectancy with specifics for others around the world. And just for fun, suppose you were a 27-year-old woman in Washington State. How many years, how many life expectancy years would you expect to have for a 27-year-old woman in this state? And you can see all the other rich countries, they have longer life expectancies. But the Czech Republic does a little worse, Poland does a little worse, Ecuador, Hungary, Kyrgyzstan. So some of you may be in that category, a 27-year-old woman. And so the sad truth is we don't have that many years to look forward to compared to other countries. So let's just take women and let's look at women in Washington State and the other rich countries. And this is a graph over the same time period of Washington State women's life expectancy over time. And we are one of the healthiest states in the country. So this is how our best are doing, and not that well. Well, that was data to 2021. Now, last month, the Washington Post and the CDC reported that our life expectancy went up a little bit. but it didn't go up enough to eradicate what had happened with COVID. This is the uptick from 21 to 22. And today's Washington Post has an article, so I'm always scanning the newspapers. So this is an article in today's paper saying we have a life expectancy crisis, but it's not a political priority. And that's something to really understand. Nobody in the political sphere is talking about our dying young. And I think if we're going to start seeing health improvements, that has to change. So what have you, what's the most important idea? Does anybody want to talk a little bit about themselves and say, what's the most important idea you've encountered in your medical career so far? I've already told you in when I used to harangue my smokers in the ER, and then I learned that Japan had so many more smokers than we did, and they were the longest lived country, and I really had to change what I thought was true. Any other sort of aha moments you want to discuss or share with the rest of the group? The biggest question that you might have in your training at this point, you've been, you've had a lot of clinical experience. You've learned a lot in medical school. Any big questions that are in your mind? I think I heard some discussion in the breakout group I was in. Okay. So let's move on and try and dissect the mortality data a little bit more in the United States. So this is just life expectancy by racialized groups from 2019 to 2021. And those who are of Asian background have the longest life expectancy. Notice that Hispanics or Latinx have slightly better life expectancy outcomes than whites. Blacks do considerably poorer, and American Indians, natives, do the worst. And if we take the 2021 65 years of life expectancy, that would put American Indians, if they were a country, behind 144 other nations. So there's a tremendous difference in health outcomes within the country, and we've seen differences from 2021 to 2022, the report from the CDC in health improvements. Here, Blacks, American Indians do the worst, Asians the best, and notice how Latinx do better than whites. So we're really talking about racism, and systemic racism or racism in its various forms can be considered a fundamental cause of health inequalities. So what I want to do right now is play a 1-minute video about studies that have been done since the 1930s. So I hope you can hear this.
Which doll is the black doll? And which one is the white doll?
That one.
Which doll is the pretty doll? Which doll is the nice doll? Which doll is the bad doll? Which doll is the nice doll? And which doll is the bad doll? And why is that doll pretty?
Because she's white and he has 2 eyes.
Which doll is the ugly doll? Why is that doll ugly?
Because because he's black.
Which doll looks most like you?
Like me.
Yeah, which one looks like you?
And that one,
Okay.
that doll.
That's the most powerful 1-minute video I can show about racism. What kind of racism is being depicted here? Well, some people classify racism as internalized, personalized, and structural.
There's
And
there's a comment in the chat from Rachel, internalized.
yes, good. So is this accurate? I mean, some of you have the skin color, and do you grow up having already internalized these ideas? You know, as a white guy, I can't speak to that, but I think it's really true. So let's look at racism as and what it means. So this is a page of notes from my medical school back in March 31st, 1971. So I wrote there, this is actually a scan of the notes on that day. Maternal mortality, 1951-53, #1 in the world. So we had the best maternal mortality, 67.7 maternal deaths per 100,000 births. And then the box below that, by 1966, our maternal mortality had dropped to 29, but Sweden saw a much bigger drop from 69 to 11. Well, you know, this was something I wrote in my notes back then. Maybe I was not paying attention well that day. So I went to the, report that this was based on, a WHO report. And there's the numbers for 1951-53 in the left-hand number column. And these are the numbers 15 years later. And all those green arrows are countries that had seen faster improvements in maternal mortality than the United States. So we are having a significant crisis in maternal mortality, not just that other countries are seeing faster improvements, but in the period 2003 and 2013, 8 countries in the world, according to this study, actually done at University of Washington and published in The Lancet, had increases. So you remember the question of which countries have seen increases? Mali is not in this list, but the United States is there. So this is getting a little bit of press. That is, our maternal mortality is not doing so well. And when we break it down by ethnicity, so these are maternal mortality data for 2018, 19, and 2021. Notice that non-Hispanic Blacks, all 4 columns are higher than any of the other racialized groups. So Black maternal mortality has increased over this period significantly. And this is really striking. It's increased in the others as well, but not nearly as much as in African Americans. If we look at education, because we tend to believe that the answer to everything is stay in school. These are African American and I can't see the and white and black. The orange are the Black with maternal mortality, whether they didn't finish high school or graduated from college, and they're higher than the white or the or the Hispanic. So no matter what level of education an African American woman has, her maternal mortality is still higher than any of the racialized groups. And we'll get to this in a case in a minute. The issues about being young is when most of the difference in mortality outcomes occurs. So these are probability of dying at different age groups, and the orangey bar shows the United States, and at every age range here up to 24, we have higher mortality rates. Remember the question I asked about a 15-year-old being alive at age 60? So these are the rates for all the other rich countries do better. And this just highlights the United States having higher female adult mortality than Peru, Tunisia, and Sri Lanka. So something is going on that is really not so good. Another graph. So if we reach ages 80 and 90 and 100 on the right-hand side, our mortality is not that different than the other rich countries. It's really fourfold higher at age 30, the chance of dying compared to the other rich countries. So things need to change early in life. It's not at the end of life. So I asked about how many fewer children would die every day if we had Slovenia's child mortality rate in a question. And there you see Slovenia's child mortality rate decreased quite rapidly in the 1950s up to 1985 when it surpassed the United States. And this is a calculation I have my students do, namely, if we had Slovenia's child mortality rate, we would have some 40 plus children not die every day. So it's really difficult to try and put real lives into this, but we get upset at a few shootings a day, but every day 40 plus children die that wouldn't if we had Slovenia's child mortality rate. Now I chose Slovenia before because it was the country of birth of our former First Lady. But there's something special about Slovenia in that we are not seeing the inequality in Slovenia, and I won't go into this graph in great detail, but the blue is the Slovenia, and these are incomes, and the upper line is the darker blue line is the United States. So Slovenia has some really remarkable outcomes. So I want to look at a case, and so I have to get rid of these. Let's see, what do I do? Okay. So I'm going to read this case out. Then I'm going to ask you to go into your breakout groups and discuss. And this is an obstetrics case, but you're going to see this kind of a case in your clinical work. So you're working at a federally qualified healthcare center in the Riverside neighborhood of downtown Spokane. And you see a 25-year-old Black woman on a repeat visit, and this time she's concerned about her pregnancy. In your previous history, you knew that her mother died shortly after delivering her, and the patient was raised by her grandmother. Your patient became pregnant at age 17, delivered a premature infant that died shortly afterwards. She's become pregnant again and comes in today concerned because she heard about high maternal mortality in the United States and that Blacks were especially vulnerable. And she wants to avoid a bad outcome for herself and her baby. She's in tears and asks you for advice. In your social history, you discovered that with help from her grandmother, she went to college and graduated. Now, some background information on Riverside has the lowest life expectancy in Washington State. It's within the Spokane city limits. The state maternal mortality, our state, is 15.6, and that's 10 times that of the best nations. And infant outcomes for college-educated Black women are also higher. So what are the options for people in her situation to avoid bad outcomes? So can we go into breakout groups and discuss what would your advice be for this woman?
Hey Rita, I don't see a breakout link on my end.
Oh, okay, let me see. Oh yeah, for some reason you guys are unassigned. Oh, maybe because you weren't on when I made the rooms. Okay, I'm gonna put you in rooms now.
I had some Wi-Fi issues. Awesome,
Oh,
thanks.
no worries at all. I was just trying to understand why you were unassigned. Let me put you in rooms now.
Switch devices.
Yeah.
Yeah, I thought about outside of like prenatal care and medical follow-up and interventions, which I think are really important. Thinking about this person holistically and what kind of social supports they may need, who they live with, how they get to appointments, like access to nutrition and foods, and really think about what barriers that they may have in all those regards, and how we can support them.
Yeah, I like the social determinants of health that you brought up, Chris. I just have no idea what like actually. I'm sure he'll give us the answer, but like I have no idea what's actually driving this difference. I would imagine a lot of it is like the social determinants of health.
Yeah,
So, like,
I think
the-
that's, sorry to chime in here, everyone. I think that is like the underlying question, right? Like coming back to like what we were talking about earlier, like personal habits versus like systems issues. Is it something that like you can change, or is there some kind of structural issue that like we're just up against in terms of care being offered that like you can't really change this through an individual choice? I think you're getting at like exactly the crux of the issue. Sorry, I didn't mean to shut off all debate or discussion.
I think this would be a really difficult discussion to have, is if this patient is knows about these statistics and is wanting to discuss why these things are happening, and to feel sort of helpless in what we can immediately offer to address these things. Because I think a lot of this is probably going to be that inequality is harmful for health and leads to health inequalities as well. And on a short-term basis and on like an individual level, it's very hard to address those things outside of like the political and legislative and all those realms.
Hello.
Hey.
Rita, we're just recognizing what a difficult question this is.
Yeah, no, I think it is. I mean, I think that it's possible that this is just a structural issue and like it's not something that can be dealt with individual choices, which is what makes it hard.
Yeah.
Yeah.
She's got a lot of things against her, it sounds like her family history, structural things. Austin, you said something like she has to encourage her to advocate for herself. And that's like good advice and also unfortunate that we have to encourage patients to advocate for themselves.
Yeah. But then even then it's kind of saying like acknowledging the issues, but then maybe that would make her like feel even worse.
Yeah.
Or like
It's on you.
expect bad things to happen. Or,
Yeah.
it's like, what does she advocate for? And like if she's, it'd be tough too, because then like you could be sowing like doubt or like paranoia that the providers aren't gonna be trusting you. So it's like, is this pain normal, or are they, doubting the pain that I'm having? I feel like then it's like all these levels of like, yeah, if I say things, is it gonna be worse? Because if she starts doubting like the system, but then also you want her to doubt it. So if she does push back, but
Yeah.
in what ways? Yeah. I don't know.
I think also we don't do enough asking. So just asking her, what would make you feel most supported in this pregnancy? What would make you feel like you are safe and that your concerns are addressed? Like write that down and then, we can meet again and figure out a way to hopefully make that happen.
Yeah, that's a good idea too. Like maybe her question is a little bit different than what we're thinking. There's like a few more tangible concerns that we can help with.
Yeah, because that's like big population. How do we connect it back to this patient specifically?
Rita, can you end the
Are we-
breakout groups?
Yes, let me do that now.
Good. Sorry to barge in.
Okay.
Were you able to go between? It looks like you
Yeah.
were. We know you were
that
able to
worked
go
out very
between.
well. Thank
Okay.
you.
Yeah.